morning, everyone. So, title for today's presentation is Pyogenic Cerebral Brain Abscess. This is the paper I wrote in 2022 itself. Till now, it's published in three journals like Research and Reviews, Journal of Neuroscience, STM Publications, Journal of Neurosurgery and Neurology Research, Auditum Publication, and Journal of Neurology and Neuroscience, Insight Medical Publishing, IMED. There goes a few introduction of mine. So these are the journal's site and issue, volume number, issue, and about the journal. So quickly move into the abstract. Abscess in the brain, like basically to know what is brain abscess. Abscess in the brain have been one of the most challenging wounds, both for surgeons and trainees. It is a packet full of pus of infected material in the part of brain. It is an important neurological disease that can produce more deadly diseases. Since the beginning of the era of CT, like before computed tomography, the diagnosis and treatment of these organizations has become simpler and less invasive. The results have been improved with the development of diagnostic techniques, neurosurgery, and comprehensive antibiotics. Rare bacterial abscess are usually caused by use of chemicals in oncology, longevity in patients infected with the human immunodeficiency virus, that is HIV, and immunosuppression associated with organ transplant. Surgical treatment options did not show significant differences. So in mortality rates, but lower rate of illness were achieved with a stereo-guided curiosity. You got stereo-directed antidepressants, antibiotic, best treatment based on effect of culture, and repeated desires expressed in result of periodic CT scans appear to be the most appropriate treatment for brain tumors. Immunosuppression and comorbidities, early neurological condition and intraventricular fractures were important factors influencing patient outcomes. Traps and mutations in diagnosis and treatment of brain tumors have been discussed in this study. So in 1893, surgeons reported only one death in 19 patients with brain tumors. Unfortunately, until the advent of CT method, the result in patients with brain tumors were not as satisfactory as in McEwan's series. The use of CT and MR imaging, the emergence of microbiological diagnostic techniques, and the production of comprehensive antibiotics have improved the results over the past 20 to 25 years. Regular use of CT scans can facilitate the detection of tumors in the brain and make patient follow-up safe. The mortality rate drops from 22.7 to 45% to 0 to 20% after regular use of CT scans. Prior to the advent of CT scans, brain tumors were commonly diagnosed and removed completely. However, simpler and more secure diagnostic techniques have stereotactic aspiration, a viable treatment option, especially for large and non-cortical ulcers. Also, in some cases, CTs can make safe and effective treatment with surgical intervention. However, there is no consequences on the treatment of tumor in the brain. The need for surgical intervention, the nature of surgical procedure, is still in doubt. So, the origin of abscess, from where it originates. Cerebral abscess occurs in patient with the following predominant conditions: conjunctival pus, for example, anterior sinus infection leading to the anterior cruciate ligament, sphenoid sinus infection leading to enlargement of cavernous sinus and an infection of the middle ear, mastoidea cell leading to temporal lobe and spinal cord. Number two, hematogenous or metastatic spread, example lung and intravenous shunts, congenital heart disease and endocarditis, dental diseases and GI diseases. Number three is headaches. Number four, neurosurgical procedure and immunosuppression. According to previous research, the most common cause of boils in the brain was direct transmission from the middle ear, meninges, mastoid infections, and paranasal sinus. So prior to 1980s, CSD 6 to 50% and sinus otitis infection appeared to be the most common symptom in brain tumors and in children. The advent of diagnostic techniques, antimicrobial agents, and advance in cardiovascular surgery have led to a decrease in number of tumors in brain due to CHD and sinus. Otitis infection and an increase in ulcers in patients receiving immunosuppressive therapy as a result of reconstructive procedures. In patients, HIV positive people who have been living longer and those who are receiving chemotherapy for cancer treatment. Many abscesses appeared in 1980s in infants and patients with depressive disorders, and they were diagnosed early for 6 months. So nowadays, hematogenous or metastatic proliferation has become a very common factor in brain tumor formation. Organisms that cause tumors in the brain are usually derived from bacteria, Peptostreptococcus and Streptococcus spp, especially S. viridians, and microaerophilic organisms are more common in patients with coronary heart disease, cyanotic heart disease, and shunt bypasses from right to left without the usual filtration of pulmonary vascular tissue. In CHD, decreased arterial oxygen uptake and increased blood viscosity may cause focal cerebral ischemia and serve as a nidus for many diseases, especially in the combination of gray matter and white matter, usually in the spread of MCA. CHD has sometimes been an important cause of childhood ulcers, but there has been a decline in these cases due to advances in heart surgery and use of broad spectrum antiretroviral drugs. Bactericidal, Peptostreptococcus, and Streptococcus spp are often identified in brain tumors caused by a combined spread. This spread is the result of osteomyelitis surrounding air sinus. The risk of developing cerebral palsy in an adult with active otitis media is 1 to 10,000 per year. But in a 30-year-old patient with active infection, the life-threatening risk is 1 to 200. Streptococcus, S. aureus, Pseudomonas, and bacterial SPP are more common in lung diseases, lung abscess, emphysema, bronchitis. They are most common in distribution of MCAs and are often repetitive. Staphylococcus, Streptococcus, Clostridium, and Enterobacter spp are more common in patients with often headache trauma. Soot wounds, open skull openings, and external bodies in the brain parenchyma, and fractures of skull with CSF fistula cause abscess in the brain, often associated with traumatic brain injury. So the fungal infections, Toxoplasma, Staphylococcus, Streptococcus, and Pseudomonas spp are identified in non-immune patients who are infected with HIV, organ transplant, chemotherapy, or steroid use. Branch-infected fungal infections, example aspergillosis, block large and medium-sized vessels, resulting in cerebral arterial thrombosis and infarction. Stridal infarcts can be converted into septic infarcts by a tumor-related structure. Abscess can also be caused by a joint spread. These lesions are most commonly found in the posterior fossa and lobe of the brain. The mortality rate due to fungal tumor ranges from 75 to 100%, despite strong treatment with amphotericin. Still has a strong representation of anaerobes, 30 to 50% in patients with brain tumors. Additionally, a typical bacteria such as nocardia and actinomyces spp may appear in affected patients. Although positive civilization rates have reached 100% in studies of careful management of clinical models, adverse cultural events remain as high as 50 to 30% in most series, especially in patients where antimicrobial treatment is initiated before surgery. Polymerase chain reaction analysis of S recombinant DNA and sequence may identify viruses at the level of species from tumors in the brain. This method is fast and useful, especially in identifying slow-growing and fast-moving organisms. Next one is lumbar puncture. That has been considered dangerous for patients with a brain tumor, but it is usually caused by strong suspicion of concomitant meningitis and or ventriculitis and reveals only 10 to 30% of positive CSF. Cultures in which organisms such as those implanted in gut are found. Although a large portion of deaths were thought to be caused by lumbar piercing during the onset of labor, recent studies in which multivariate modifications were used have failed to reveal such a risk. Therefore, lumbar piercing may be recommended in patients with brain tumors where there is no increase in intracranial pressure and with clear signs of meningitis and ventriculitis. So quickly move to the pathogenesis of brain abscesses. Abscess in brain develop as a result of parenchymal infection by pyogenic bacteria, starting as a local cerebritis and transforming into a strong wound surrounded by a well-vascularized fibrotic capsule. Brain tumor in humans have been based on diagnostic findings during CT scans or imaging sessions. The first stage or early cerebritis occurs from day 1 to 3 and is characterized by the accumulation of neutrophil, tissue necrosis, edema, microglial and astrocyte activity is seen in the phase and continues throughout the development of the tumor. The intermediate phase or late cerebritis occurs in days 4 to 9 and is associated with macrophage infiltration and lymphocyte. The final or capsule stage occurs from day 10 onwards and is associated with the formation of well-developed vascular wall, which actually closes the wound and protects the normal brain parenchyma from further damage. The capsule formation is usually early from 10 to 13 days and is usually thin on medial or ventricular side of the abscess and usually ruptures in this way. After day 14, late capsule formation develops with pleotic collagenous and granulation layers. In addition to reducing the rate of infection, the immune response, that is an important part of tumor formation, also destroys surrounding normal brain tissue of infection. The immune response, that is an important part of tumor formation, also destroys surrounding normal brain tissue. This support is found in experimental models in which harmful areas are exaggerated in comparison to the natural environment for bacterial growth, which is reminiscent of an overactive immune response of brain tissue, which often spreads beyond the initial focus of infection. Therefore, controlling the intensity and the duration of antibacterial immune response in the brain may allow for effective elimination of bacteria while minimizing damage to the surrounding brain tissue. As mentioned earlier, injury sites in both experimental models and tumors of human brain are exacerbated in comparison to the natural environment of viral growth, reminiscent of most effective immune response, reporting on the extended region of affected tissue involvement associated with brain tumor compared with the condition focused on initial shock. Ilian suggested that the production of inflammatory mediators following S. aureus infection continued, effectively increasing damage to normal surrounding brain parenchyma. So you can see the imaging images here. The below, the first one is pyogenic abscess. Okay, A, this one the region which is showing, and the C when it finally goes and ruptures the vein or the portion of the brain. This one is metastasis. This one is fungal abscess. Goes to the down. So specifically, the continuous release of pro-inflammatory mediators by activated glia and internal immune cells may work through a constructive response, look to enhance the recruitment and utilization of newly recruited inflammatory cells and glia. This will effectively promote the antibacterial inflammatory response through a vicious pathological circle, culminating in extensive collateral damage to normal brain tissue. So recent research supports the ongoing immune function associated with experimental tumors in which a high level of interleukin 1b tumor necrosis factor A and a macrophage inflammatory protein 2 were detected between 14 and 31 days after exposure to S. aureus. In line with the long-term inflammatory mediator, T.S. aureus infection was found to cause chronic disruption of the blood-brain barrier, which is associated with continued presence of peripheral immune cells and glial function. Overall, these findings suggest that intervention with anti-inflammatory compounds following adequate bacterial neutrality may be an effective strategy to reduce damage to surrounding cerebral parenchyma during brain tumor development, leading to improved cognitive and sensory effects. R microglia and microcyte microglia response in S. aureus is defined in terms of burning mediators expression and is generally found to be of the same quality as those detected after a lipopolysaccharide exposure. Although studies containing basic microglia and astrocytes from toll-like receptor knock out mice cerebri an important role for this receptor in regulating S-dependent activity. Or is it is clear that additional receptors are also involved in the in-glial response to this virus. It is surprising because these pathogens have the potential to have harmful effects on tissues such as CNS, which have limited ability to regenerate. So the effects of glial function, cell function on brain tumor context of almost numerous. First, parenchymal microglia and astrocytes may be involved in initial recruitment of specialized bactericidal phagocytes in the CNS by the expression of inflammatory chemokines and cytokines. Secondly, microglia exhibit bactericidal activity of S. aureus in vitro, suggesting that they may also be involved in initial inhibition of viral replication in the CNS. However, their bactericidal in vitro activity does not compare with that of neutrophils or macrophages, suggesting that this activity may not be a major mechanism of microglia effect of severe infection. Thirdly, activated microglia have the potential to influence the type and level of antibacterial adaptive immune reaction through its phase 2 complex, administration of the histocompatibility complex, and exposure to the co-stimulatory molecule. Finally, if glial activity persists in context of progressive inflammation, continuous release of inflammatory mediators can damage the normal brain parenchyma. So let's move to the clinical presentation. There are no pathogenic clinical symptoms. Most patients with clinical symptoms, depending on the location or major impact of the lesion. Headache, nausea, urination, fever, dizziness, fainting, and muscle spasms are the most common symptoms. These symptoms develop rapidly, however, about tumor lesions. The flu is less pronounced, and only 30 to 55% of patients with the flu are 38 to 5 degrees Celsius. Capture is a symptomatic mark in 16 to 50% of patients. Focused neurological loss is seen in 40 to 60% of patients, depending on the location of the lesion. Papilledema is not available to patients who are 2 years old. Patients such as with low ability to limit infection and cranial enlargement are possible. However, three symptoms of brain tumor, like headache, fever, and neurological deficits, can also be seen in 15 to 30% of patients, like paralysis, muscle weakness, and many different symptoms may be present, and degeneration is often very rapid. So, diagnosis: how to diagnose? The photographic feature of the tumor in the brain depend on the stage at time of photography and the source of the infection. The development of an abscess in the brain can be divided into 4 stages: early cerebritis, 1 to 4 days; late cerebritis, 4 to 10 days; formation of the first capsule, 11 to 14 days; and 4, capsule formation late, that is 14 days. Most abscesses show a lot of surrounding edema, which usually occurs during a late cerebritis or the first stage of capsule formation, which follows a major effect. Blood clots, which can be seen in form of endocarditis, cardiac shunts, or paralysis of the pulmonary vascular malformations, usually numerous and are identified at the junction of gray and white, and are found in MCA area. In the earlier stages, a CT scan was performed without the addition of brightness, can only show low comfort with great effect. In the later stages, a complete peripheral ring may appear. For CT scan, obtained after the administration of different materials, the development of same ring remains in the later stages. In the early stages, the capsule will be difficult to visualize. Using conventional techniques and double-sided CT therapy is often helpful in interpreting tumor closer. Metastatic tumors, advanced gliomas, cerebral infarction, cerebral palsy or hematoma, lymphoma, toxoplasmosis, debilitating disease, and radiation necrosis. That should be remembered as a separate diagnosis of brain tumor that appear as enlarging lesion rings. So the techniques in neuroradiology have simplified the diagnosis of multiple brain tumors. The incidence of multiple abscesses in the brain, which is reported to be 1.8 to 17% of patients, that is the pre-CT period, and 23 to 50% in modern cases. The finding of MR imaging also depend on the stage of infection. In the first stage, lesions exposed to MR images may have a low T1 weighted signal and a high signal in T2 weighted, enhanced and SCAD images with a high signal in T2, that is weighted images, both in pit and surrounding parenchyma. The abscess shows hyperintense rim in T1 weighted images, often indistantly, and a strong rim in T2. As best, images in CT scanning, imaging MRI usually show a developmental ring around the abscess. The abscess usually grow to white matter away from the gray vascularized gray matter, as well as narrowing of the middle wall. However, the mark of developing ring is not specified and should be examined in the context of clinical history. The size, inconsistency, and stiffness of the developing ring elevate the tumor. Most cases are possible fungal infection. I'll show you in figure 1. That is in DW images. Limited streaming bright signal may be visible. This helps to separate tumors from necrotic neoplasms, which are usually not prevented. Although not all tumor follow this route, fungal abscess and tuberculosis may increase the distribution and low signal in DW3. So this is the MR images. You can see the ring over here. So MR images with the sagittal T1 obtained in different patients after different treatment, showing cystic lesions that improve the ring. So the left image shows MR admission. Image reveals a small straight, well-marked cystic lesion. Here you can see the ring, which is well marked, with the central perilesional edema. Pathological examination revealed cystic pilocytic astrocytoma. And the right one shows the MR reception image showing thick, distinct cortical tension, thin on the ventricular side, peripheral lesion with perilesional inflammation and constipation due to vasculitis and cerebritis of the surrounding parenchyma. Pathological and microbiological examination reveals a pyogenic brain tumor. So the numerous studies also show the benefit of DW imaging in distinguishing between necrotic or cystic ulcers and brain tumors. Initially, DW hypotheses were thought to be helpful in differentiating toxoplasmosis and lymphoma. In a study, ADC limit of 0.8 was proposed, where ADC values 0.8 may favor lymphoma over toxoplasmosis. However, that study showed a significant increase in ADC values in toxoplasmosis and lymphoma, as the author concluded that in most patients, ADC values were not clear in making a distinction between toxoplasmosis and lymphoma. However, DW imaging has a high sensitivity to the detection of rapid ischemic changes in the cortical and deep white matter that can occur in cases of infectious vasculitis. The tumor hole in brain shows regions of increased levels of partial anisotropy, which have a relative variability compared to other cystic intracranial lesions. So this information may prevent misinterpretation of diffusion tensor image in formation as abnormal mass of white matter fiber associated with large lesions. Intracerebral tumors are characterized by certain resonances in MR spectroscopy that are not detected in sterile human tissue. MR spectroscopy modality has been shown to be particularly useful in distinguishing between brain tumors and other cystic ulcers, information that can be used to speed up implementation of appropriate microbial treatment. Metabolic substances such as succinate 2.4 ppm, acetate 1.9 ppm, alanine 1.5 ppm, amino acids 0.9, and lactate 1.3. That may all be present in bacterial tumors that can be treated or immediately after initiation for treatment. So let's move to the treatment. There are 3 treatment options for brain tumors: medical, respiration, freehand stereotactically, or neuroendoscopically guided, total cut, that is surgical. In choosing the appropriate treatment option, the following factors should be considered: Karnofsky performance measure, primary infection, predisposing condition, and number, size, location, and stage of the tumor. Modern treatment for brain tumors often include a combined surgical and therapeutic approach. So how to manage the medical management? Antibiotics play a key role in regulating abscess in the brain. The agent characteristics such as brain infiltration and previous use of intrathecal or interstitial treatment should be known prior to treatment. Choosing the right antibiotic, microorganism, or underlying disease should be identified. If the patient is choosing the right antibiotic, microorganism that is not in sepsis or in a critical situation, antibiotic treatment should be postponed until cultural factors are identified. We have reported 8 times the number of invasive cultures in patients receiving antibiotics before surgery. The author reported that the intracerebral material culture remained infertile, 34% of of the surgical patients. On the 76 patient whose culture was infected, that is 89%, identified one virus and 11% viruses were detected. If a predisposing condition is sprayed with hematogenous or patients have symptoms of systemic infection, blood test may be helpful in identifying the microorganism. After performing blood tests on 49 of the 122 patients who had a clinical presentation of systemic infection, fever, and leukocytosis, only 13% of those patients had blood clots that raised viruses, positive rate 26.5%. 7 of them have the same pathogen in both cultures of the blood and brain tumor. Blood test is a very small, inexpensive, and quick way to detect a pathogenic microorganism. Despite the low levels of positive findings, blood tests should be taken from every patient who is suspected of having a brain tumor and who has symptom of systemic infection. Only medical treatment can be considered if patients are poor partners of surgical intervention in the following terms. If the lesions are numerous, 1.5 centimeter wide, found in clever places, or there are concomitant diseases such as meningitis or ependymitis, the most important objection to empirical treatment without microbiological identification. Another microorganism may cause an abscess. At least one aspiration procedure can be very helpful in identifying a microorganism if the patient does not have the coagulopathy. Treatment alone is most effective if treatment is started during cerebritis. If the wound is 1.5 centimeter wide, if the duration of symptom is 2 weeks, and if the patient shows improvement in first week, systemic antibiotics have been given for 6 weeks. Although some institutions now offer 2 weeks of intravenous antibiotics, followed for up to 4 weeks of oral antimicrobial treatment. If the microorganism is undetectable, 6 to 8 weeks of intensive treatment may be required. Despite appropriate treatment, at 5 to 10% recurrence rate has been reported in brain tumors, which can be caused by discontinuation of treatment early. I reported a series in which the duration of antibiotic treatment was not based on a specific time, but rather on levels of C-reactive protein levels. In addition, a high level of C-reactive protein can be used in differentiating the tumor of the brain from other lesions that improve the ring. 3 of the 26 patients had been elevated C-reactive protein level and were found to have recurrent abscesses. It did not happen again in patients, their level returned to normal. Antibiotics and hyperbaric oxygen therapy were given for a total of 4 weeks in 13 patients. Even in patients who did not have a bacteriological diagnosis, overall the first operation failed in 2 patients, that's 15.3%. 2 re-emerging tumors were resuscitated for 6 to 9 days, respectively after the initial procedure. However, long-term radiological tests failed to show a recurrence of tumor in any of these conditions after 9.5-month follow-up period. The main difference between the research and other reported cases in reduced duration of antibiotic treatment. Nowadays, with easy radiological monitoring of brain tumors and extensive antibiotics, doctors often choose treatment, especially if the pathogen can be detected based on blood culture, CSF, or a specific desire. It was reported in 56 patients who were randomly selected for treatment anticipation or surgery for the brain tumor and found no statistically significant difference. In fact, boils in the brain cause significant physical stress in patients, and surgical stress should not be added if necessary. Corticosteroids can be used, but they have side effects, and their use in treatment of vasogenic edema due to an abscess on the brain is still debated. The adverse effect of dexamethasone on capsule formation has been demonstrated in experimental studies. and made similar comments about the effect of corticosteroids. However, it is reported that corticosteroids do not inhibit capsule formation and that they only act as reversible forces. Mampalum and Rosenblum reported high mortality rates in patients treated with corticosteroids, but these patients were in a critical state at first and had decreased level of awareness. These authors recommend the use of corticosteroid in patients with significant perilesional edema that was radiologically diagnosed and reported in a previous study of 26 patients who showed no adverse effect on when corticosteroids were used in patients with intracranial tumors. It should be borne in mind that steroids may reduce the brightness of the tumor capsule in the early stages of infection, and this may be false indication of radiological development, or it may delay the diagnosis. Surgical management. Throughout the history of neurosurgery, treatment of brain tumors has been challenging. Non-surgical treatment of suspected small brain tumors with antibiotics has been recommended. Reasonable control of intracranial mass lesions required the establishment of a thorough diagnostic prior to the initiation of therapeutic measures. Indeed, patients presenting with progressive neurological deficits resulting in significant neuroradiologically verified brain tumor by neuroradiologically verified decompression, both by surgeon and internist. Different types of surgical procedure have been used in treatment of brain tumors. The choice of procedure has been the subject of much debate. Craniotomy, previously promoted in past when no antibiotics or CT scanning was available, is no longer used. Breathing repeated as needed or by draining water has replaced the exertion efforts completely. However, an open surgery procedure is still preferred to treat brain tumor with a combination of treatment and surgical removal in the following cases. If there is evidence of increased intracranial pressure due to major brain tumor effect, there is difficulty in diagnosis. If the abscess is the result of traumatic injury presented by foreign objects, if the wound is located in the posterior fossa, and if there is any consideration of fungal infection, even stress with craniotomy or craniectomy will be helpful for patients with a serious emotional condition. Because diagnosis based solely on clinical, radiological, and neuroradiological findings that may be non-surgical treatment decisions should not be made without a thorough pathogen diagnosis. Control of the brain stereo strategy in the brain, which allows for both diagnostic and therapeutic confirmation of the desired wound content and identification of traumatic organism that has expanded since the introduction of CT-guided stereotaxis. A recent review on the research shows a series of tumors in the brain treated primarily with stereotactic techniques and a review of the 11 patient series, concluding that stereotactic cravings should be considered as an alternative treatment for all both the most external and major and related tumors. Failure of stereotactic treatment of tumor in a series of 29 cases due to insufficient appetite, lack of catheter drainage, prolonged immunosuppression, or lack of antibiotic treatment. It was therefore reported that 4 patients with brain tumor underwent surgery using a free neuroendoscopic method with freehand stereotaxy. They breathe in pus and clean the hole with antibiotics. The author reported their self-awareness with a flexible scooter, free directed or natural directed, while choosing the strongest in the children's series. It is now reported that useful of flexible endoscopes for certain important surgical procedures, such as reaching and examining the tumor in all local directions, or dealing with a strong elastic membrane that requires scissors or other implants. It is now maintained that drainage catheters do not need to be inserted into the tumor after endoscopy to be used to give him antibiotics, and desire continues within the next few days. While others are reported to place catheter in all cases but avoid drain implants in one of patients. And not a moment, surgery was needed because no tumor were left with the effect of replacement. On the contrary, they underwent subsequent surgery on their 4 patients. There are reports that no significant differences can be found in the length of hospital stay, the number of post-operative CT scans, and the duration of antibiotic treatment between traditional and endoscopic stereotactically guided aspiration. Internal sampling of abscess material through operations and smear arrangements for a microscopic analysis and biological detection of tumor is fraught with pitfalls. Most tumor-related necrosis should be separated from tumor necrosis. Small or large areas of coagulation necrosis are often seen in glioblastomas. Sometimes the necrotic site of a tumor is replaced by a large infiltration of a polymorphonuclear leukocyte that transforms the necrotic area into a epiphytic, resulting in a misdiagnosis of brain tumor. So on the other hand, very lesional gliasis of the abscess may be marked to mimic low-grade astrocytoma, although in the non-neoplastic proliferation of active astrocytes, cellular cells are usually low and individual cells are very common. They are rarely associated with cellular domains, especially of growing astrocytes with pleomorphic and hyperchromatic nuclei. Brain tumor was classified as cerebritis, stage 1, when polymorphonuclear leukocyte deficiency and perivascular erythrocyte were recovered, and encapsulation, stage 2, and frank pus, a polymorphonuclear leukocyte, constipation, necrosis, granulation tissue, and active gliasis were detected. This provided a better understanding, simplification of pathological features, as well as effective pathological radiological communication. On the other hand, advanced neuroradiological methods can be used in different diagnoses of these lesions. In deep multi-site lesions and near the ventricle wall, a reduction of 1 mm between the ventricle and brain tumors will increase the rate of fracture by 10%. Although a combination of intracal and intravenous antimicrobial therapy has been recommended for intraventricular rupture, treatment strategies in the specialized group of patients remain controversial. Alternative therapies have been recommended, including the following. Number 1, emergency craniotomy with immediate removal of the abscess, emergency evacuation with washing of the ventricles, and placement of ventriculostomy, accompanied by administration of intraventricular antibiotics, a 5-step treatment regimen, including open ventilated craniotomy, ventricular detoxification, intravenous administration of antibiotics for 6 weeks, intraventricular administration of gentamicin twice daily for 6 weeks, and intraventricular drainage for 6 weeks. So the outcome of research, the mortality rate ranged from 40 to 60% in the pre-CT period and decreased to 10% from the beginning of the CT period to 2000. After 2000, the mortality rate was reported to be between 17 to 32%, mainly due to the major changes in epidemiology occurring today. Compared to previous report, the incidence of brain tumor caused by sinus otitis infection has decreased, while those associated with deficiency of immune system have increased significantly. It is a challenge to treat patients who are receiving cancer chemotherapy or immunosuppressive therapy for organ transplant, or who are infected with HIV. So we reported a 2.8-fold increased risk of adverse outcomes in patients with immunosuppressive immunity. Other comorbidities such as diabetes mellitus or cirrhosis are also factors that have a negative effect on the outcome. Worst predictions were reported in the patient presenting with low Glasgow-Coma scale score. Then reported that 62% of 21 patients with the first figure of Glasgow-Coma scale 9 either died or fell into a vegetarian state. Intraventricular rupture is a traumatic and often fatal complication of brain tumor and is associated with a high mortality rate. Deaths were reported in 84.5% of 129 patients in a research review between 1950 and 1993. Another recent study from Japan, the overall mortality rate was 38.7%, 12 of 31 patients. A series of 62 patients, where 48% had adverse effect, severe disability, vegetative status, and even death due to intraventricular rupture of brain abscess. The patient neurological pre-treatment condition is an independent factor, a significant effect associated with the outcome. It is rare for survivor to experience neurological sequelae that include hemiparesis, epilepsy, and psychiatric disorders. Abduction is a long-term risk by 30 to 50% for patients suffering from brain tumor. The delay time can be up to 5 years, but it is sought for older patients, started immediately and last for at least 1 year due to the high risk of subsequent fainting in patients with brain tumors. Treatment may be discontinued if no significant
epileptogenic activity can be demonstrated in electroencephalograms. Abscess management is one of the most important factors in both arousal and nerve effect. It was therefore reported that after surgical removal of the abscess, severe neurological deficits 5.2% compared to 0%, and fainting was 47.7% compared to 31.2% were observed. Compared with stereotactic cravings, the location of the abscess did not contribute to the formation of fainting. However, the hypotenuse areas around the tumor cavity were wider in patients treated with surgery. These areas were thought to be damaged brain parenchyma that was causing neurological deficit and epilepsy. Recurrence rates are estimated at 10 to 15%. The observation period should be held for at least 1 year. The solution to surrounding edema and loss of developing ring should be recorded at this time, which can take up to 6 months. In the first 6 weeks, wounds that do not show or decrease should be sought as well. Surgical treatment may be recommended for patients with dementia or ulcers that cannot be resolved radiologically.